donate a lot of money to the University of Michigan School of Public Health, correct? Okay, so now I'd like to invite Rhyme up here. All right, Rhyme.
Okay, so clearly we've got a gigantic team. So real quick, I want to let everyone introduce themselves. Everyone is dedicated to and contributes to this project, but if we all tried to talk, we'd be here all day. So Z and I here drew the short straws, and we'll be your voice of the many today. So I'm Nick. I'm a graduate student in biomedical engineering. I'm co-president of RHYME.
Hi, my name is Zishan. I'm the other co-president. I'm an MD PhD student here, and I'm doing my graduate work in the School of Public Health.
My name's Dominic. I'm an electrical engineer, and I head up sort of the design aspect of our team.
My name is Vedant Ram, and I'm currently an industrial operations engineer, and I focus on the ergonomics of the design.
Hi, my name is Sudhan Masrisha, and I'm a computer engineer, and I'm working on the prototyping and the design of the product.
Hi, I'm Aditya Shankar. I'm studying computer science, and I'm working on the software end of our product.
I'm Harish Kilaru. I'm studying economics. I'm in charge of a lot of the business side, so market assessment and building our connections in India.
I'm Neha Chopra. I'm part of the College of Engineering, and I'm working on the design as well as the business plan.
I'm Meg Erkinen. I'm studying chemistry, and I'm helping with the public health and business plan initiatives.
Okay, you guys can all sit down. We don't want to crowd the stage. All right, good to go. So, let's see, is it? Okay, there we go. So, statistically speaking, 2/3 of the people in this room were born as yellow as Maggie Simpson, right? But you're all here and you're distinctly unyellow, so why? Well, chances are when we were all born, most of us at least, faced something similar to the situation on the left, where you see we would receive a lot of individual attention from nurses, and we would be run through a battery of diagnostic tests as soon as we were born, everything from blood oxygen, jaundice, EKG, to about 40 other things depending on the situation. This was to make sure we were healthy, and if we weren't, those problems were addressed in order to mitigate the impact to our health. But if we were born in a public facility in India, as you can see on the right, we would receive much less individual attention due to understaffed and under-resourced clinics, and would be lucky to get even 2 to 3 of the diagnostic screenings that we'd receive in a standard Western hospital. And the lack or the absence of those diagnostics really has some tragic consequences. For example, in the developed world, you see only about a 3% prevalence of lower respiratory tract infections. But in India, it's almost 10 times that. And we can see that again in something like jaundice, where kernicterus, which is permanent nervous system damage caused by very severe jaundice, it's a non-disease in the US, but in India it accounts for 5% of all infant deaths. And disparities like this, we think, are unacceptable, so that's where we come in. Rural Innovations in Medical Engineering is a team of medical engineering business students from the undergraduate, graduate, and PhD level that are working to solve these problems. And our mission is to address global health disparities by providing solutions based not only on innovative design, but on solid business and on social education. And to accomplish that, our first project is focused on 2 of those screenings that I mentioned earlier, blood oxygen levels and jaundice. And we believe that every child should receive both of these screens at birth because they can be measured very simply and non-invasively via light. And so we want to take these 2 measurements and combine them into one device. This device would be simple, easy to use, and certainly cost-effective. You can see an early prototyping sketch here, basically a screen, a switch for moving between measurements, and a button for actually taking those measurements. And while existing devices cost in the thousands of dollars to do the same sort of measurement, we believe we can do ours for under 50. So with that cheaper alternative, we want to reach more people in more places, and ultimately we want to generate long-term cost savings. We can do that by reducing or catching diseases before they become too severe. So for example, kernicterus, the disease I mentioned earlier, can cost up to $9 million over the lifetime of one individual. But it can often be prevented by simply placing severely jaundiced babies in sunlight. So we recognize that this device alone really isn't enough to change the healthcare standard in India. And so we need to make sure we educate our users, the clinicians in these public facilities, about what our device can and cannot do, when to use it, what to do with the readings, and really why they should use it. For example, informing them that the commonly used visual diagnostic, which is something that's common even in US hospitals, has been repeatedly proven to be less than 50% accurate in actually diagnosing the severity of jaundice. So now I'm going to hand it off to Z.
Yeah. So the question is, who are we? Who are our customers? Who are we trying to target? So we're hoping to bring our solution to the overstaffed, under-resourced public healthcare workers, physicians, and nurses in the tens of thousands of public health centers and NGOs in India. I'll just stand over here then. Yeah. And what kind of impact do we expect to have? So there are almost 2.5 million Indian newborns are at risk for kernicterus annually. 250,000 have congenital heart defects, and 10 million cases of pneumonia in India. And so that leads to us having a potential diagnostic capability of diagnosing about 13 million infants annually in India alone, and almost 160 million cases worldwide. And so not only will this be saving costs, but more importantly, it's going to be saving lives, and we believe that. And so what kind of work have we done so far? Again, we were established as a student organ, as a team in August, and since then we've done a lot of different kinds of things. So very importantly, we've done a needs assessment, and that's actually allowed us to pivot a little bit. So at first we were targeting rural centers, but then we realized that a lot of these newborns are being born in public health centers, even if they live in rural areas. So we've kind of transitioned over to serving the public health, urban public centers as well. Additionally, we've also been, again, validating our prototype. You met our engineers already. They've been working very hard on that. And we've also been submitting to other competitions. There's Optimize here at the University of Michigan, as well as the global competitions at Rice and the Thorne Prize at Yale. So we've definitely been spreading ourselves out and getting our word out as much as possible. And so as much work as we've done here, we realize that there's no way we can just sit up here, develop a product, and expect it to work in India. So we know, we have a very good understanding of that, and that's why we're going to India in May. And so what we're going to be doing is we're going to be piloting our education plan, piloting our prototyping, and getting a better understanding of what the need actually is in India. And we're very ready to pivot if we do see something that we need to pivot on. And I think it's very important to go to India. And so we're not doing this alone. I mean, you saw we have a very big team here, and that's obviously very crucial to what we do. But we also have developed key partnerships elsewhere. We're working with Centricycle and Dime, which are two successful examples of startups in India that are in the same space that we are, working on medical devices. And these are kind of going to be our primary exit strategies that we might be able to sell our device to. They have a very well-established kind of infrastructure there. As well, and also when we go to India, we're going to be going to 5 different hospitals, and one of our main partners that's helping us with that is the NRI Academy of Sciences in India. So it's a very key partner that we need to have in India. And finally, we're collaborating with students at Yale University on our education pilot. And so these partnerships have already started to pay off. So to me, this is one of our most important slides. This is from a physician in India who has told us that, we've told him about the device, and he's told us that this is something that could be very useful. This is something that they might need, or that they would definitely use. And this is kind of the reason we do this kind of work, because our mission is that care, or our belief is that care should be independent of socioeconomic or geographic factors. So this disparity to us is completely unacceptable. And so we're hoping to empower the underserved healthcare providers with innovative diagnostic capabilities in order to close this healthcare gap that we think is very clear. And so with that, thank you for your support. We really appreciate it. And visit our website at rhymeglobal.org. We also have a Facebook page. And with that, we'd like to take any questions.
So, first I want to say once again, thank you. I think this is a terrific idea. It seems like you've assembled a really special kind of team, and I'm wholly supportive of it. I urge you to keep it up. But there's one nagging thing that I have in my head, and it's very similar to an old joke. So I don't know if you've heard I'm sure you've heard the joke. Astrophysicist, engineer, and an economist marooned on an island have to figure out how to open a can. Astrophysicist, the engineer, have complicated schemes. The economist says, let's assume a can opener. So talk to us a little bit about how this thing's going to work.
So, I'm not sure I understand the question.
I didn't really do the joke justice. That's the problem.
So you're asking about how we've established our assumptions?
No, but
how
a
does
key
it work?
component of this, as we discussed it, is you have this really cool device for $50 when the rest of the world with really huge, smart competitors hasn't come up with anything better than $1,000.
Yeah, I think Nick. I think you can answer this with the. I'll just go. So
We don't need a lot of detail here, but just a little bit of sense of the kind of work you've done.
So the way one of the key parts of this technology is a very simple design aspect, which is both pulse oximetry and bilirubinometry. They use light in order to it's either light reflectance or light transmittance, and that can basically be accomplished by diodes. By emitting diode light into either the finger, and we're actually going to be at the sternum or the forehead. And so because of that, we're really using very cheap parts in order to do that. And the reason why, and I think Nick mentioned this earlier, the reason why other companies have not done this is because the market that we're trying to serve is a very niche, very underserved market that is not necessarily the most lucrative one. And so that's kind of the two-part answer to that question, I think.
Can I add to that?
Yeah, sure.
So I would add, it might be against my better judgment, but that I don't think we've yet stumbled upon exactly why the existing products are so ludicrously expensive, judging by what we know now and how that stuff can be measured. Our best assumptions right now are, one, the more advanced models that include all these extra features that we don't necessarily need for our market, and the second being the generous markups that medical companies often put on their products because the hospitals they're selling to can afford them.
So can I ask a follow-up then? What of the current products that are on the market and the capabilities that they have, what % of those capabilities will your product have? Is it half of their capabilities? Is it 90%? I mean, help us understand.
Yeah, I don't try to quantify it, but basically we're taking the main function and just that. So the main function of measuring bilirubin and pulse oximetry and simplifying it to make it the cheapest and the fastest solution versus, some of these extraneous data holding and recording features or, interfacing with other technologies that these clinics simply don't have and would be extraneous to them. Donnie?
Quick question. How would that device work with brown, black, or white skin?
That's a really good question and one that we're currently working to address. So one of the things that makes current device, actually, Dom, do you want to explain this? Yeah. Come up. Okay. So Dom's the lead on this.
Yeah, so also kind of speak to some of the previous questions too. Some of the current devices, the technology they use kind of does a multi-wavelength analysis, and so you're able to kind of factor out for melanin levels. What we're hoping to do is by kind of taking a step back from that, essentially we would probably do some sort of like calibration or determining measurements, because you're absolutely right, that is a big issue that you do have interference based on skin color. But really all that means is you have to essentially factor that in when you're taking a measurement. So even though the values might be weaker for someone with higher melanin levels, the difference is still there. And so you'd essentially have to account for that in the categories and sort of when you're interpreting the results.
We have time for one more question. Thanks, Tom.
Go ahead. No, I just hope you ask the question I want to ask.
It's unlikely. Mine has to do with regulatory issues. So have you thought about what would be required in India? In the United States, you'd have to get this through the FDA before you could start testing.
Yeah. Obviously in the United States, we'd have to get it through the FDA, which is more than we're looking to do, which was one of the reasons we're not trying to market in the US. Also, there's not really a market here. For India, from our experience in working on past projects, the regulatory issues are pretty lax for something as non-invasive as this. And so there aren't specific guidelines that we're binding to. It's definitely something we'll be looking more into once we know exactly what our device, or exactly how it functions and how well it works.
If you manufacture in the United States,
right,
and then ship to a foreign country, you still need to go through the FDA.
The FDA. Thank you. That's helpful.
use the dean's prerogative. So one of the reasons for going through the FDA is the false negative and the false positive. Have you thought about the consequences of underdiagnosis, which is clearly status quo, but overdiagnosis? Are there any likely adverse outcomes from overdiagnosis?
So that's a question of what do you do with whatever results you get from a screen. So in this case, we believe that the adverse outcome from an overdiagnosis is basically just putting the infant out in sunlight or treating the jaundice underneath a UV lamp. That would be kind of the result of having someone who might not actually have a high bilirubin, which is a very low risk health effect. The other possibility would be to further measure the bilirubin using a transcutaneous bilirubinometry, which would, serum bilirubinometry, where you get blood out, and that has risks associated with in terms of infection of just penetrating with the needle. But again, that would just be a follow-up measurement. So and then that would either confirm or reject the initial screening test. So we believe that again, based on the treatment that's available right now, it's not a high risk.
Great.
Thank you very much. Well done. Very well done. Again, another group that really seems like a startup company.